Hello and welcome to Lesson 1. And this lesson is going to be about vestibular anatomy. We are going to take a look at the vestibular system and how it works. And later on we'll be then applying that information to how we assess and provide intervention for people with vestibular dysfunction. So I hope you've had a chance to take a look at the chapter in the book. I recommend using as many other sources as possible to see if you can figure out the vestibular system, online sources, or if you have an atlas that would have the vestibular system in it. Those would be really good things to look at, as well as your textbook. So we have a learning objective for today, and we're basically looking at the constructs associated with normal vestibular function. So we're looking at all the structures involved in that to help us figure out vestibular performance. But first, I think it's really important for us to consider how vestibular rehabilitation is evidence-based. There's such a great body of evidence out there for vestibular rehabilitation. One of the things that interested me in vestibular rehab in the first place is that it's based in neurology and evidence. So we have that good basis for us, to dive into vestibular rehab. We also have treatment tools that are based in evidence that have been vetted in the literature through research. And we also have a lot of foundation of evidence that gives us very prescriptive ways of intervening, but then within that we can allow for some creativity in practice and focusing on what a person's own wants and needs are in the realm of vestibular rehab. I have a very extensive reference list that I've left attached to every PowerPoint, so you can see some of the body of evidence that is available in vestibular rehabilitation. So I'm making that available to you. So what is balance? When we consider the balance system, what is it made up of? Of course, I'm sure that you PTs learned this in PT school. If we have anyone taking this class that's not a PT, you may have still spent time learning about the balance system. I know we do a little bit in occupational therapy school. Balance is made up of three systems. It's made up of our vision, it's made up of our vestibular system, and it's also made up of our proprioception. What we feel through our legs and feet and large joints is what makes up our vestibular system. Now, the vestibular system itself has several structures involved with it. It has the inner ear labyrinth. It has the vestibular nerve, which is cranial nerve 8, which then goes to the vestibular nuclei, where the cell bodies are located, and then has projections to multiple areas, and we'll be talking about some of those projections in just a bit. So here is our ear diagram. Of course, we can see the external ear. We can see the middle ear, where the three bones transmit the sound to the inner ear. And there in the inner ear, you can see the brown portion, which is the cochlea. That's the hearing part. And then we have the lavender or light purple portion, which is the vestibule and the labyrinth, which is where our vestibular portion is contained. So it is named after the area that is called the vestibule in the inner ear. And here you can see that just a little bit better. So let's take a little closer look at these structures. We have in the vestibule the otolith organs, which are the utricle and the saccule. One sits vertically and one sits horizontally, and they help us to sense gravity. Now, I've always had a hard time remembering which one is vertical and which one is horizontal, the utricle or the saccule. So I finally found a little way of doing that, and that is utricle is horizontal, and I can't remember, so I'm always going which is UH, utricle horizontal. Well, that means then the saccule is the vertical one. If it works for you, fine. If not, you can find another mnemonic way of helping you remember that. Then we have the three semicircular canals. And remember, you have 3 on one side and 3 on the other side. So the posterior or inferior semicircular canal, and all of them have two names because medical things always seem to have more than one name just to confuse us all. But the posterior semicircular canal sits at a little bit of a downward angle, like so. The vestibular organ, by the way, is behind. I'm going to show you my ear here. If you feel the mastoid bone, it's kind of behind the external ear. And if you go in about 1 inch, that's where that vestibular organ is located. It's, yay far into the head, behind the ear at the mastoid bone. So if you're looking at the semicircular canal orientation, again, the posterior canal sits like so. The anterior canal or superior canal sits like so, kind of like if you think of these like moose antlers, and if you think of these like wings on the back of your head. And then you have your horizontal canals, which sit not quite level, but at about a 30-degree tilt. So if we want to get those canals in the level, we have to tilt our head down a little bit. And you'll actually see later on, as we're doing some of our vestibular testing, much of our testing actually involves tilting the head down a bit. And that's the reason why. Those canals are oriented with a little bit of an upward angle, and we have to get them in line. Now, one of the things to note about the vestibular organ is that inside of that mastoid bone, it's actually a negative space. Now, what do I mean by that, a negative space? Rather than there being something that looks like this little vestibular organ that you could actually take out, it actually is as if you took a balloon and you blew it up, and then you poured cement around the balloon, and then you popped the balloon, and then you'd have this space left that was balloon-shaped but was hollow inside. That's exactly what the bone is like. So the bony labyrinth inside your head is actually a negative space, allowing for the membranous labyrinth to line it and to provide the soft structures of the vestibular system. So this is a microscopic look at the otolith organs, and this would be horizontal, so it would be which one? The utricle. And the otoliths, they're actually extruded from the supporting cells in the macula. So they're not just sitting on top as they are in this picture. They're actually all the way through that otolithic membrane, which is a real sticky gelatinous substance. If you took honey and left it out and it got really good and dry but not quite lost all its stickiness, that might be more the texture. So these otoliths are supposed to be stuck down in that gelatinous fluid, and as we tilt or turn our heads or ride the elevator or ride the moving walkway at the airport, those otoliths will shift with the shifting of that otolithic membrane, which will then bend those hair processes, and depending on whether it's moving toward or away from the kinocilium, which is the tall hair, then our brain can tell whether we're moving toward gravity or away from gravity in horizontal and vertical planes. So that is the purpose of our otolith organs, is that they sense where our head is in relationship to gravity and in relationship to linear movement. Now the semicircular canals, remember those orientation, we have the superior canals or the anterior canals, same difference. Then we have the inferior or posterior canals, and then we have the horizontal canals. Those canals sitting opposite each other, each of them have an ampulla in the end of them. So altogether we have 6 ampulla. Inside the ampulla is the cupula, which is a little fan-shaped or sail-shaped sensory organ that sits in there and waves with the fluid movement. Now the fluid that's inside the semicircular canals is called endolymph, and it is thick like honey, not thin like water. So that when we go to move, as we're turning our head, that endolymphatic fluid doesn't move as rapidly as the rest of our head, so it kind of stays still. And relative to our head movement then, it will bend that cupula in the direction of the motion. You can see the green arrow that's pointing down there. That shows that sense of motion, bending that cupula. And that motion tells our brain how far and how fast we're moving, and it tells acceleration and deceleration of the head, in particular with angular or rotary motions. So that's the function of the semicircular canals. Now we have all kinds of central connections, and the point of this slide is to help us remember all the places that the vestibular system can impact. After the cell bodies in the vestibular ganglion, the axons then extend to a vestibular nuclei where we have some synapses, and those synapses go to several places. One is all the different nuclei of the oculomotor muscles. So those oculomotor nuclei, do you remember what those control? Those control our eye movement's ability to track a target, to focus on a target, for our eyes to work in parallel so that they can both go the same direction at the same time. Now there are also some projections to the cerebellum. If you remember, there's a flocculonodular node, and that gets information from the vestibular sensory inputs to tell our brain a little bit about our head position in space and our head position in relation to gravity. And those cerebellar adjustments then happen to control our posture, to help our posture. I guess I should mention back with the oculomotor one, the reason why we have all those connections is because the vestibular system helps stabilize our eyes on a visual target when our head is moving faster than 30 degrees per second, which is about like this. So if we start moving our head any faster than that slower pace, the thing that keeps my eyes on the target is not my eyes, it's my inner ears telling my eyes how far and how fast to move in order to stay on the target. And in fact, that difference of me turning my head right and my eyes go left, me turning my head left and my eyes go right, is called a gain of 1, because when my head goes 30 degrees one way, my eyes go 30 degrees the other way to keep my eyes stabilized on that target. Then we also have connections with the cerebral cortex, with the limbic system, with the basal ganglia, in order to have connections with our emotions, in order to have connections with the vagal nerve, and in order to have some conscious awareness of the movements that we're making. So that is why we feel so yucky when our vestibular system is so upset, is because of all the connections to the limbic system and connections to the vagal nerve. Now, this is a little reminder about the vestibuloocular reflex. You might have learned this at some point in time, but we're going to do just a little bit of a refresher here. So the red axons are excitatory and the black axons are inhibitory. And in this example, the head is moving to the right. So as the head is moving to the right horizontal semicircular canal is stimulated by that head acceleration, which then deflects the cupula. There is an excitatory message that goes to the vestibular nuclei. Now in the left, we're getting an inhibitory message that turns off all the messages coming from the left semicircular canal. It's a little bit simplistic because these actually are going up and down. It's not just a matter of on and off. It's a matter of how much signal is being sent. So what happens then is we have excitatory messages going to the lateral rectus muscle of the left eye and the lateral rectus or the medial rectus muscle of the right eye, and inhibitory messages going to the medial rectus muscle of the left eye and the lateral rectus muscle of the right eye. The net result is that the eyes turn left while the head is turning right in order to keep our eyes on the target while our head is turning. And that is how the vestibuloocular reflex works. It also works with the inferior and posterior, the inferior posterior and the superior and anterior canals. Now those work in what's called a push-pull pattern. So when our head is moving in this sort of an angle, we are activating the right anterior, left posterior, sometimes called RALP, right anterior, left posterior, R-A-L-P, RALP. Then we have the other direction where we're activating the left anterior, right posterior, and that would be called LARP, L-A-R-P, left anterior, right posterior. And that those movements in conjunction with each other, that push-pull motion, is also part of our vestibular systems telling our eyes which way to move to keep our eyes on the target while our head is in motion. So we have all these central connections, and they create these reflexes. The last things we were just talking about was the vestibuloocular reflex. We also have, with those central connections, our vestibulospinal reflex, which is what helps keep us erect when our head is moving. We have the vestibulocolic reflex, which helps right our head when our body is doing other things that tend to tilt us off center. It helps right our head on our neck. We also have the autonomic connections, which is that vagal nerve, those vomiting centers. So if you ride a fair ride you don't like, you might vomit. That's the connection that can happen there. And then those limbic connections. So we actually have emotions and feelings about our vestibular system. That's why kids think riding the merry-go-round is fun. That's why we think riding roller coasters are fun, because of those limbic connections that creates that fun for us. Now, I just want to have a word here about diagnostic testing. Because these are some of the things that you'll get when you get a history from a client. You might have some medical tests with MRI, CT scan, or cardiac that'll tell you a little bit about what's going on with those systems. But the ones that tell us the most about how the vestibular system itself are functioning are going to be your audiogram, because hearing loss can happen when there's a vestibular loss, the video nystagmogram or electronystagmogram. Nowadays, it's more video nystagmogram that takes place. An audiologist will do that test, and it's a very comprehensive test that lets us know how well the vestibular system is working when the head and the body are in motion. There's also rotary chair test, which looks at vestibular responses while the whole body is being turned. We have positional testing, including the Dix-Hallpike testing, VEMP, which is one thing that tests how intact that inner ear is, and computerized dynamic posturography, which is something that therapists can do as well, but audiologists have been known to do it. That lets us know how well the vestibular system is working in tandem with the somatosensory system and the visual system in order to maintain our balance. I do want to make a note about precautions on yourself or anybody that you're practicing on, as well as patients for the future, that you need to make sure their neck is okay first. So you're going to want to check out their neck range of motion and ask them if they have any pain or if they have any back pain. If you're working on someone who might be at fall risk, especially an older adult, then you want to take special precautions not to make them fall. Check if the person has any circulatory issues, especially if they've ever had any compression or compromise in their vertebrobasilar artery. You wouldn't want to do these tests on someone who has that condition without getting cleared from their physician. Watch for autonomic reactions. Even in people who are quote-unquote normal, you might create some autonomic reactions in them, and if that's the case, you probably want to stop. You don't want to get them to the point where they are having nausea and vomiting, and those are definite indications to stop. In extreme cases, people can have seizures from vestibular stimulation. And you also want to always be aware of coexisting diagnoses so that you know what's going on with your particular client. And that is our first lecture for the summer. Thank you very much.